the next topic, which is, I am so glad that this topic is going to be presented by Ms. Aparna Gopalakrishnan. She is from our Shankaretralaya, an optometrist, and she's actually doing her PhD in the area of myopia. So no better person to talk about the optical corrections, that is the orthokeratology, spectacles, and contact lenses for myopia control. Where do we go from now? And so she's going to be speaking from my system here. So we're going to be loading this up in just a second. Over to you.
Thank you, ma'am. I just take this opportunity to thank Dr. Meenakshi for giving me this forum and AIOC to let me speak in this forum here. Thank you so much.
Speak louder. So here, wait. You have to go here and do the forward, okay?
Yeah. Okay. So by now, we are all aware that by 2050, half the world's population is going to be myopic, and there is an epidemic. And our community work at Shankaretralaya also showed that 1 out of 4 children at the age of 15 in urban cities are already myopic. So this is proving that the predictions are really true, and we are moving towards an epidemic of myopia. So of course, myopia is causing a lot of impact because of the economic burden that it is creating, and the risk that myopia carries itself with. It is at risk for various other retinal complications that can cause permanent visual impairment. So ideally, we have to start in terms of identifying children who are at risk and trying to prevent myopia. But once myopia sets in, there is a lot of time for the eye to elongate and for the eye to get more myopia. And so it's important for us to start thinking about myopia control strategies early. So if you look at myopia control strategies, you can broadly divide them into pharmacological and optical. And I just want to give a brief on various optical interventions that are now available and what the latest evidence is telling you. So the very first optical intervention that was talked about was bifocals and progressive addition lenses. And the idea was that myopes, the observation that myopes tend to spend more time at near, and they also have a higher lag when compared to the emmetropes. And this high lag is causing an hyperopic defocus at the fovea. And this hyperopic defocus is a cue for axial elongation. So based on this, there were a lot of trials on bifocals as well as progressive addition lenses, but the results were not very satisfactory. Bifocals were giving contradictory results. There were a lot of trials which showed that there was no significant difference between controls and children with myopia, except for a study by Cheng et al., where they had studied children giving executive bifocals alongside a prismatic bifocal, and they did find that around 50% of children were 50% efficacy was there with in terms of bifocal contact lenses, bifocal spectacles. But unfortunately, this study these results were not replicated in other studies. So the COMET study, which is the correction of myopia evaluation trial, which was the longest study which looked at the efficacy of progressive addition lenses. And they found that there was a statistical significant difference between the controls and children who were prescribed with progressives, but the significance was not really clinically significant. It was just a 0.25 diopters, and even that vanished after a period of 5 years. And they also found that it's a subgroup of children who have higher lag and near esophoria tend to perform better with progressives. And there was a subsequent study that looked at only the subgroup of children who had higher lag and esophoria. But here again, the statistical significance was there, but there was no clinical significance. So if you just look at all the studies that had looked at bifocals and progressive addition lenses, except for the Cheng et al., which the rest of the control strategies showed close to 30%. So then probably there was something else that was causing the myopia progression. So world moved into, based on the animal studies, it was found that when you do a myopia correction by traditional concave lenses, there is a peripheral hyperopic defocus that is created, and probably the peripheral hyperopic defocus is the reason for the axial elongation and myopia progression. And so subsequent designs were aimed to create peripheral, to correct the peripheral hyperopic defocus or to create a myopic defocus at the periphery. So I'm just listing few of the commercially available multifocal spectacles that are showing promising results, although there are a lot of clinical trials with various designs going on now. One such available optical strategy is marketed by Zeiss, which is called the MyoVision. Again, this is a central distance zone with a peripheral addition. This, the initial 2-year study period randomized control trial showed that the efficacy was around 30%. There was not much of clinically significant difference with this lens design. But the most promising one, which is just now arrived, is the defocus incorporated multifocal segment technology lenses, which are now promoted as MyoSmart by Hoya, where its essential 9 mm is given for the distance correction, and multiple lenslets surrounding the central 9 mm, around 33 millimeter zone, is creating a peripheral myopic defocus by incorporating a 3.5 diopter addition surrounding the central. And the 3-year data has just come out, which shows that over a 3-year period, the myopia progression was only 0.5 diopters in the control, in the treatment group. And not only that, there was also a significant efficacy noted in terms of axial growth, and the problem that this could cause some peripheral blur, which was also addressed in this study. And the study reported that the children had good complaints over the 3-year period, and the adaptation to peripheral blur was also accomplished within few days. Not just that, even though the mean progression was 0.5 diopters at the end of 3 years, 70% of the children did not progress more than 0.25, which is really impressive. But none of these lenses are currently available in India, but we might hope that this is available in the coming years. Moving on to the soft contact lenses, similar to multifocal bifocals, multifocal soft contact lenses also look into peripheral hyperopic defocus and try to induce myopic defocus or correct the peripheral hyperopic defocus in the periphery. One such lens is the MySight by CooperVision, which is the only lens that is actually approved by FDA for myopia control. And the efficacy is again impressive, similar to DIMS technology lenses. Here also there is a 59% reduction at the end of 3 years with children who are wearing MySight contact lenses. And there is also an impressive efficacy in terms of axial length control. The other new design that's now again in trials are the extended depth of focus lens designs, where they try to manipulate the higher order aberrations and increase the depth of focus in the retina, thereby creating a myopic control. These lenses are not yet commercially available, but the initial trials are showing promising results, and there is a 50% efficacy reported in the control trial result. But there are more trials that are ongoing, and we will know about these lenses in a couple of years. Moving on to the next, orthokeratology lenses, which is really old of all these control strategies, which are reverse geometry lenses that are worn overnight. And because of the lens design, there is a flattening at the central cornea. And because of the mid-peripheral zones, which are steep, there is also a peripheral myopic defocus, and the hyperopic defocus is corrected, and that's how this works as myopia control. Though there are not a lot of RCTs available, the reported RCTs show some amount of axial length reduction of around 0.3 mm when compared to 0.6 in the control group. And a recent meta-analysis said that the mean difference was around 0.28 between controls and ortho-K wearers. So these are some of the orthokeratology lenses that are available in India, and most of the lenses are available up to -5 and 6, except for one. And it's important that we monitor myopia control in orthokeratology lenses. We can only monitor it in terms of axial length elongation instead of than when compared to other modes where we look at the fraction. Here it is important to document the axial length and monitor in terms of axial length growth. So of course, there is risk with all myopia control strategies. We do not know how the rebound is in all of these new contact lens designs, though Ortho is known to accelerate progression. And the other important factor to consider is the corneal infiltrates and infectious keratitis that are inherent with contact lens mode of control. But the rebound strategy, the rebound really found in multifocal spectacles or progressive addition lenses. The rebound is a concern in orthokeratology lenses. So spectacles are relatively safe and there is no adverse effects, and you have to really select the patient and train and give proper lens care and maintenance instructions to the children, and parent and patient education is really important when it comes to contact lens mode of control. So where do we go now? Of course, every diopter of control is going to improve the quality of life, and we have to move from prescribing single vision lenses for managing myopia to start early with any of the control strategies that are available. There are also combination techniques that are tried out, and it's a fast changing field, and we need to be updated and follow the evidence-based practice. Thank you so much once again to Dr. MS ma'am to have given me the opportunity to present here. Thank you.